So thank you again for joining us tonight for this engaging and educational talk with Dr. Ron Karni. Dr. Karni serves as Division Chief of Head and Neck Surgical Oncology and Associate Professor in the Department of Otorhinolaryngology at the McGovern Medical School at UT Health in Houston, Texas. His clinical practice focuses on multiple types of head and neck cancers, and Dr. Karni is a regionally recognized leader for transoral robotic minimally invasive surgery. He has authored publications on robotic head and neck surgery, workup of the occult head and neck cancer, and integrating evidence-based methods in otolaryngology. Not only is Dr. Karni at the forefront of treating cancer, but he is also paving the way in survivorship. He understands the importance of recognizing the side effects of cancer treatment and treating them early to maximize the patient's quality of life. Thank you, Dr. Karni, for giving this presentation. And with that, I will turn it over to you.
Thank you, Brittany, and good evening and welcome, everybody. As you've heard from Brittany, we are delighted to have everybody here this evening on our Zoom webinar here talking about something that's important to all of our head and neck cancer patients. And so I want to share with you a little bit about my story and how I got involved with survivorship and ultimately with lymphedema therapy. And you'll get that here within the story. We will certainly make time at the end for some questions. We've got an interactive talk today, so there'll be some questions posed to the audience where we can get your participation and hear from you. And really, I welcome any comments or questions either at the end of the forum today, or you can certainly reach out to me via email or phone call. I myself am a practicing head and neck oncologic surgeon here in UT Houston. Kind of slowly over the last couple of years, now maybe 7 or 8 years, have developed a keen interest in not so much the way we treat the cancer patients, that's an ongoing interest, but really what happens in the abyss after the ring has been, after the bell has been rung, when the radiation is finished, when the chemo and surgeries are done, and the patients have to recover and rehabilitate. And so much of that is important. And I found a real void in my discipline, both in terms of the knowledge that my peers on the MD side have, but also in terms of the accessibility that patients have to what is obvious and good and guideline driven for them to help them recover their deficits and recapture the quality of life that they had before. And what really is the call to action in this conversation is exactly that. So much of head and neck cancer, especially in the HPV era, can be recovered and rehabilitated, swallow and lymphedema being cardinal among those. And so oftentimes we see it as not, even at some of the best treatment centers in the country. And so we're drawing attention to that by this phone call, by this Zoom webinar. But just by being here tonight, I know that you are my allies in that battle. These are my disclosures. So we'll talk about what's happening now and what the future is for head and neck cancer survivors. We'll talk about what's currently known about head and neck lymphedema. And I would say in the past years, I would give this talk and I would say there was little known. I think that body of evidence has now grown dramatically. And there are some really exciting ongoing trials that will elucidate really the connections between lymphedema and other aspects of quality of life like swallowing. Which is such an important connection. It's important for us to understand that lymphedema and swallow go hand in hand, and the recovery of one ties into the recovery of the other. And then we'll introduce the tactile Flexitouch as really one of the mainstays, what we contend to be the mainstays for the future of lymphedema treatment that dovetails well with the rehab services like speech therapy and lymphedema therapy that patients should get exposure to. And so I always start this talk with this slide. This is the most important slide in all of head and neck. In my opinion, it's now probably 15 or 20 years old, but it really speaks to the increasing incidence of head and neck cancer. Of course, 3 times more common in men than in women. Non-smokers, younger, they come in with considerable volume of disease and they need considerable treatment. And these patients, when they come in the door, they're not like the patients we had 30 years ago in head and neck cancer centers, where we had Vietnam veterans who were smokers, who were in their 70s and 80s, who had ongoing other major medical problems like cardiac disease and strokes and other cancers where we weren't expecting them to live 10 or 15 years. Here we've got a 40-year-old healthy male who's got a lymph node, so he's got metastasis, he's got a primary tumor. He's young, he's healthy, he's working, and he's going to require pretty intense therapy. And then most importantly, and the good news is we actually cure in rough sketches here at least 80% of these patients. And so we're going to create a population of patients who are survivors, but have to carry with them the side effects of the treatment for many, many years. And we're opening a new chapter in head and neck cancer because we're now going to see patients who are even 30 and 40 years survivors. And we'll see things, side effects of treatment that we probably have not uncovered up to now. And including some of the side effects like lymphedema, but others as well. You know, osteoradionecrosis, not the topic today, but a really big one that will come up and become, I think, a burgeoning topic in the future for talks like these. There's at least 500,000 head and neck cancer survivors in the United States. There's probably 40,000 new ones each year. These patients are now, you know, they're the baby boomers, so they've crossed well into the Medicare age now. And beyond, and they're also an educated population. They've got the internet at their fingers. They want to know not just, you know, who is treating me and what is my treatment, but they're going to shop around. And when they shop around, they're going to want to know who's taking care of their side effects. And so everyone knows, you know, oh, my surgeon does this laser treatment, and my radiation doctor does this new technology, and you know, immunotherapy rather than chemo, and all these things. But despite all the new stuff, if you will, that's coming down the pipeline in the cancer world, the things that make it to billboards, we are still treating patients pretty intensely for head and neck cancer. We don't really have an alternative outside of some very important but small clinical trials to you know, 60 centigrade of radiotherapy combined with some version of platinum-based chemotherapy that still maintains the highest rate of cure. It's still very effective. It's effective across head and neck cancers, but in particular for this HPV disease, which has been our epidemic, if you will, our pandemic in the ENT world for some 25 years now. And we still see an increase year over year in these numbers of patients, and we treat them pretty comprehensively. So there's a lot of talk about de-escalating the treatment, but we're just not there yet. And in most situations, it's not yet appropriate to decrease one treatment in lieu of cure. Everybody wants cure first, and then they want to talk about side effects. But today we're going to really talk about side effects because we are curing these patients, and then they'll live long enough to have a lot of these side effects. And these are the list. And this is really the abridged list. It's kind of like the old-fashioned encyclopedia. You could really put a multi-volume textbook on what happens to patients after they get radiation plus minus surgery plus minus chemo. And the question then becomes kind of an MBA question, a question for a business person or somebody who looks at process. Who's in charge of these side effects, and who's best positioned to manage these side effects? You know, so in a typical, let's say, head and neck cancer program in an academic center, or, you know, a vibrant community-based cancer center, you've got, you know, well-meaning ENT doctors, you've got radiation doctors, chemo doctors, but who amongst those is really an expert on issues, for instance, like neck range of motion and fibrosis, or the psychological and depression sides of things, or management of that bottom bullet point that you see there, spine problems, shoulder and dystonia, which we talk about more and more, the musculoskeletal side effects of head and neck cancer treatment, the stooped shoulders, the inability to extend one's neck, the frozen larynx, the loss of taste. And so we don't really have quite well organized teams around management of these side effects. And we know that these side effects are common. It's predictable. If you put somebody through 6 weeks of radiation, you know they're going to have it. So this is a good moment for us to kind of introduce the audience and find out who is listening today. And so you've heard about me, and now I want to hear who you guys are. We've got, wow, 158 people participating this evening. That's a huge number, and delighted and honored to see that. The numbers are coming in. We have pretty close splits here, actually. So we've got about 22% of you are lymphedema therapists. We've got another 13% occupational therapists and about just under 20% physical therapists. We've got one other physician. We've got speech therapy today at 30%, and we've got another 13% that are other. And that's great. I'm delighted to have all of you, and you guys all have, you're all stakeholders in this conversation about what we do. How do we reorganize head and neck cancer around these needs? So what ends up happening in my office and what ends up happening in this paradigm of a disease that's highly curable, but also the side effects being very serious, is that the doctor walks into the room at the end of the treatment, maybe 2 or 3 months after the treatment's done, and says, well, good news, your PET scan is clean, your CT scan shows no cancer. And we're expecting the patient to smile and high five and walk out of there, but the patient doesn't ever do that. They are completely ripped apart by side effects, and they're of course emotionally exhausted, and they're managing a feeding tube, and they're looking for recovery. They've had disruption in their lives, and so there is this kind of men are from Mars, women are from Venus phenomenon between the doctor and the patient, and that's remedied by side effect management. That's really about the side effects, and so we in the MD side of this equation are not equipped for these things. We're not classically trained in these things. We don't understand these things. I often challenge my audiences and I'll say, who among you, among the medical doctors, can even explain what an occupational therapist actually does? And so often they cannot. So we need your help. We need all of your help. And we need to integrate you in the pathway of cancer care treatment to make this better. We here in Houston have the advantage of having TIR. TIR is a world-renowned center for rehabilitation, not only around neurologic spine injuries and stroke, but also a big wing for cancer. And we've spread out TIR across the greater Houston area. But in my own office, we have really evolved from where we started in my practice around head and neck cancer to where we are now. And what we've done is really taken and right-sized everybody. When you have that surveillance visit, when the patient comes in at the end of radiation or in that first visit after the radiation's done, and even before the treatment has begun, we make sure that we've got these people front and center. We've got obviously our nutrition people. We've got a physician, one of my best friends and partner, Carolina Gutierrez, who's a rehabilitation cancer physician. We have a speech and language pathology team, and we also have lymphedema, which is not just the in-office aspects of lymphedema, but one of the really wonderful parts about Tactile is that it's the take-home homework, if you will. It's what patients can do in between visits, and so much we know happens in between visits. Tactile helps us solve that problem. So instead of trying to solve 10 problems in 15 minutes once every 2 months, we've got the patient at home. We've got Tactile folks going to the patient's house to help them with fitting and garments and so forth. And we're getting active lymphedema therapy in between visits. So we're making progress. In our practice, we use self-reported assessments commonly to help identify what patients' problems are having. If you don't ask these questions, you won't get these answers. This is, again, beyond the pale of a typical ear, nose, and throat doctor, but it's what we do, and I think it's why we succeed with recovery relative to places that don't. If you don't ask your patients about things like constipation or financial difficulties or insomnia, you won't hear from them about it, and they'll continue quietly suffering at home. And so these questions give the patient the opportunity to say, oh yeah, I have this problem, and for us to say, okay, well, let's get down to it. Let's figure it out. And we have a second self-reported assessment. We use these published ones, really specific to things like trismus and coughing and troubleshooting the tube feeds and so forth. So, when I said before about right-sizing your tool, the visit to the ENT doctor in our practice, and it could be the med-onc or the rad-onc in your practices, or to whoever's doing the surveillance, the post-treatment monitoring, has been resized. We take the role of the MD and we put it in one corner, and we let the MDs do what the MDs do well, which is look at your scan and examine you and say, look, I don't see cancer. I think you're in good shape. But then we bring in our three other main partners in head and neck cancer, The rehab physicians, which I recognize there's not many of those, but they in our practice play a cardinal role, and they can see things from 30,000 feet that we don't on the surgeon side. The speech therapists, which are critically important, and we're going to get to that. And then lymphedema therapy, which is my contention that we really need to get every patient as we can, as many patients as we can, into lymphedema therapy one way or the other. So if you were to design on the back of an envelope, really the ideal experience for head and neck cancer patients, it would be probably 18 different visits with different providers. And that sounds like a lot, and it is a lot. And patients get fatigue, and they don't understand why they need to see this. Why do I need to see a speech therapist? Why do I need to go see a rehabilitation expert? But on the other hand, most of the stress that patients have from head and neck cancer is not just their threat to life, but actually the management of their side effects. So this is another one of those men are from Mars, women are from Venus moments where we on the treatment teams think that the patients just want to live. And of course, cancer patients want to live, but they also want to know who is going to manage their side effects and what their side effects are. That is the fear of the unknown. That's the anxiety they have in their eyes. And we can alleviate that by saying, okay, here's what's coming. You're going to have 3 months of swallow problems. Here's how we're going to deal with it. Here's our plan A, plan B, and plan C. Here's how I'm going to recover you from it. Here's our expectation that you'll recover from it. And that really alleviates the anxiety. And that's been shown time and time again. We can have not just a 1 hour talk about speech therapy. We can really have a whole meeting, a whole international congress on the importance of speech therapists front and center for head and neck cancer patients. And we know this is independent of their primary site. Even if you're getting treatment for a parotid salivary gland cancer, you're going to need, if you're having radiotherapy, you're going to need speech therapy. And that's because all these muscles are connected, and this is such a kinetic part of the body. And there's so many aspects of the treatment going on, like aspiration and so forth. There is nothing like that first hour of speech therapy. And I know I'm preaching to the choir and getting a thumbs up from many of you. So all I can tell you is that this talk does not do the due diligence that the speech therapists deserve. So this is my moment to say you guys are front and center. And to me, a patient who goes through head and neck cancer treatment and hasn't seen a speech therapist is basically kind of an F for the grade for that program. If you were to kind of grade programs on quality metrics, if you were to say what differentiates one program from another, I think one of the good ways to differentiate them is to say, well, what % of your patients are getting speech therapy, swallow therapy with a speech therapist within a month of their diagnosis or within a month of their treatment? And if one program has 80% and the other has 20%, you know which program I'm voting for. It's the one where the speech therapists are part of the pathway for treatment. Which brings us to our next audience question. What percentage of your cancer survivors in your home programs are routinely seeing a speech therapist? We're going to give you guys a few minutes here to get those answers into us. Okay, so those numbers are coming in, and it looks like only 2 people out of our audience has said that they are kind of in that 0% range, that none of the patients are seeing a speech therapist. But here's the opportunity, folks. Those of you who said that less than 25% of your patients are seeing a speech therapist routinely, that's almost 40% of this audience. And another 20% of this audience, it's less than 50%. So we have full out probably 60% of the audience today representing, I'm assuming, many places across these United States where less than 50% of the patients are routinely seeing a speech therapist in the course of their head and neck cancer treatment. We do have about 20% of you guys who are saying that you're in the 75% or higher group. So kudos to you. That's where I'd go get my cancer treatment if I needed to. But we see this all the time, and we've asked this of many audiences, and we've seen this result time and time again. And by the way, this is not, my opinion or one that you may share. This is actually in the guidelines. So we often, talk a lot about guidelines, but the guidelines really mandate in head and neck cancer in the NCCN the involvement of speech therapists, but we just too often don't see the execution on that. And this is my slide to really tip of the hat to prehab, this concept of not just catching the patients after the treatment, but really involving rehabilitation before the treatment, to educate them of the side effects, to assess what problems they have before they even started the treatment. It's very rare for a patient to walk in the door extremely healthy. So often patients claim to be healthy and have other ongoing problems that can also be addressed by rehab providers outside the umbrella of the cancer treatment. And again, alleviating the anxiety of their cancer care. This is a slide that I've carried with me now for several years because it's a nice review of the literature. And if you were to sit down for 4 hours and look at every paper written on rehabilitation, as I've done maybe a year or two ago now, and look and say, okay, what in the literature has been successful, not successful, or categorically always successful. There's two things for head and neck cancer patients would have been categorically always successful in improving their quality of life. And those are the two things bolded at the bottom, which is intervention by rehab providers, that's you guys, and intervention with lymphedema therapy. So why are patients not getting this? Why are we seeing 50 or 60% of our patients, let's say, never seeing a speech therapist, even though they have, let's say, oropharynx cancer? How are we getting away with that? What's the problems? And there are many. It's not fair to just point the finger at one issue or another. One of it is patient education. I think sometimes the cancer doctor, the chemo, radiation, or surgical oncologist have to tell the patient, this is why this is important. The speech therapist, in your case, is not about speech, it's about swallow. The lymphedema therapist is about what's going to change in your neck and avoiding the fibrosis. We also have to educate the providers. I've given this talk to my own peers many times, and it's shocking how many times I'll have a room with, let's say, head and neck surgeons and lymphedema therapists, and I'll ask the room, I'll say, who amongst you knows, as you know that the sky is blue, knows that lymphedema therapy improves swallowing? And the lymphedema therapists will all raise their hands, and the surgeons, very few of them will. So there's just not that knowledge among the MD side. And some of the most wide-eyed audiences are typically the MDs when we give these talks and share this data, because we don't classically educate for this in medical oncology and radiation or surgery. Cost is a big barrier. We know that it takes time to go see a rehabilitation specialist, that you have to sometimes travel great distances, make an appointment, pay a copay, and then there's just not enough of you. I've got a good friend who's high up in some of these rehab programs across the country, and we just don't have enough lymphedema therapists. If we were to prescribe lymphedema therapy for every head and neck cancer patient, forget breast for a moment, I don't think that the lymphedema therapists would have an appointment slot open anywhere in the country for a long, long time. And so we have just kind of an infrastructural problem here for this patient population. And this speaks to really what's happening across the United States. This is a SEER study, so it really looks at a wide swath of centers. And it looked at some 2,400 patients, but only 15% of these head and neck cancer patients, and these are real deal head and neck cancer patients treated with big time radiation and surgery, only 15%, 1 in 6, ever saw a speech therapist within their first post-treatment year. And so we can all agree that that's not appropriate, that's not right, and it's not good enough. So we're going to switch now and kind of focus on this bottom right corner of our recovery visit, if you will. Imagine now you're back in our office. It's been maybe 2 weeks since you finished radiation therapy. You're pretty glum. You've got a terrible dry mouth. You can't taste anything. Somebody put a feeding tube in you because you lost too much weight. There were about 2 weeks where you couldn't eat at all. You're chronically dehydrated. You're depressed. And you've already, started your visit today. The surgeon has seen you. They've examined you, no cancer. And so what do we make of lymphedema therapy? Where would we put lymphedema therapy in this puzzle? Why do we put lymphedema therapy? And how do we get this actually done? alongside the speech therapy. And I always say these two are linked. Speech therapy and lymphedema are linked, and it's obvious in our audience today. I heard that 25% of you are speech therapists, and speech therapists are often the ones, nudging the doctor to, hey, you better refer this patient to lymphedema as well. And many speech therapists are also in the lymphedema business, and that's no surprise because you guys know how important it is. This is my stump speech, if you will, about head and neck lymphedema, what I've learned being on the basic science research side and the clinical side. So in that regard, I want to share with you that, about 8 or 9 years ago, we started doing basic science research on how the lymphatics reorganize from where you are when you first get diagnosed with cancer to where your lymphatics are, let's say, a year later. And we did this with some pretty neat imaging technology, working alongside PhDs at our university here. And we could really create some basic science that dovetails well with what's happening clinically. What we could see on the screen when we look at lymphatic flow explains what we're seeing with the patient and the troubles the patients have in those time courses of recovery from treatment. And so I share with you both a basic science perspective and also, of course, the clinic perspective of lymphedema. And I'm also somebody who went from never thinking about lymphedema to thinking about it all the time. Thursdays is my rehabilitation clinic. We just finished a Thursday. We saw about 50 patients today, most of them head and neck cancer survivors. And so we are talking about it all the time in our clinic. And that's really been the paradigm shift for me. So I remember the world without lymphedema, and I know how much better my practice is with it. But lymphedema is different in the head and neck than it is with the breast. And there's some really specific reasons for that. Breast cancer patients tend to get worse as the day goes on. I'm not a breast cancer specialist, but I've learned this from folks like you. Head and neck cancer patients tend to get better as the day goes on. So head and neck cancer patients unanimously swallow better at dinner than they do for breakfast. And that's because of gravity. So gravity is actually one of your most basic lymphedema pumps. If we were on the space station, we'd have even a bigger problem with lymphedema. And in fact, NASA's actually done a study or two in my office using some of this technology because the astronauts, they're not cancer patients, of course, but the astronauts do get some lymphedema or something associated similar to it as well because they don't have gravity, so their heads swell. It's a well-known phenomenon. It's a bit tangential to our talk here, but suffice it to say that we cannot take all the rules of breast cancer and apply them to head and neck lymphedema. Head and neck lymphedema is also different because we've got mucosa in the head and neck. We've got kind of a hollow tube, right? We've got our throats and our larynxes and our esophagus, as opposed to the arm in breast cancer patients. But head and neck cancer patients do get better along the course of the day. So we tend to treat lymphedema aggressively in the morning. And I think that's important. We also know that we really don't have good metrics to identify if, when, where, and who, and how bad the head and neck lymphedema is. So, you'll see two patients in the office with me. Both of them are 5-year survivors of oropharynx cancer. Both of them had similar stage. One of them, their neck is supple and soft, and you probably couldn't guess that he had head and neck cancer. And the other one, his neck feels like a rock. You could use it as a cutting board. It's stiff. The larynx doesn't move when he swallows. He's got range of motion problems. So why is one this way and one that way? They both got the same treatment. And that really is the essence of lymphedema and lymphedema therapy. It's our contention that lymphedema therapy obviates or makes less likely the development of fibrosis. And once the fibrosis is there, it's hard to make it go away. I talk a lot about baseball players in my practice and soccer players. And if you haven't moved your elbow in 10 years, it's hard to imagine you pitching a baseball if you haven't swallowed effectively for months and months and months. And then you want to get back to swallowing. It's very difficult. And a lot of that has to do with fibrosis, and fibrosis ties to lymphedema. And we'll make those connections here. The biggest thing about lymphedema that we also try to explain is that lymphedema is not just that pouch underneath your chin. So often we find people coming in and saying, well, I've got this kind of swollen pouch where the lymphatics are collecting because the radiation tends to be aligned with the jugular chain along the alleys of the neck, along the sides of the neck. to us, that lymphedema, that visual aesthetic lymphedema is real, but it's really, when you see that, you're seeing the tip of an iceberg, because that same lymphedema exists on the opposite side, on the mucosal side, on the other epithelium, and it's there where the patient's having trouble swallowing. So when we see that, we always pivot and say, well, what troubles are you having with swallowing? And they often do. And interestingly, when that lymphedema under the chin goes away, the swallowing problems go away. So it's kind of like a canary in the cave, but it's not what lymphedema is. Lymphedema is really worst where the treatment is the worst, where the cancer was the worst, right? So think about that lining of your throat. Then you get cancer on the lining of your throat. Then you've got a surgeon messing around in that area with a knife, and then you've got radiation aimed at there. That's where the lymphedema is the worst. Those tissues under your chin are just pass through. And so again, you're seeing the tip of an iceberg. You're seeing really just a symptom of a much bigger problem in the pharynx. And then finally, the movement of lymphatic fluid is much more complicated than we can draw or explain in one talk today. The historic diagrams of lymphedema therapy always aim down to the chest and kind of make straight vector lines to it. But we know that lymphedema therapy is much more complicated than that, and how it flows is very dependent on each patient and their cancer. So what is lymphedema? Is it the submental swelling? Is it the fibrosis? Is it the trouble swallowing or voice or airway obstruction or disfigurement? And I would say it's all of these. So back to you. We take it back to the audience. What percentage of the cancer survivors in your program are getting any type of lymphedema treatment? And let's make this specific to head and neck cancer. So what percentage of the head and neck cancer survivors in your program are getting any type of lymphedema therapy? And you know where I'm going with this. I would say that if you're in this group where you can say greater than 75%, then your program is awesome. By the way, I'll tell you, I gave this very similar talks probably 7-8 years ago, and it was rare to have people say that they had 75% of the patients getting lymphedema. And that really speaks to the rising awareness around lymphedema. Looking at our audience today, 50% of you are reporting that less than a quarter of your patients get any type of lymphedema therapy. But I'm also happy to see that there are 13% of you that are getting that to 75% of your patients, which is great. So it's a bell curve and it's an opportunity. And I think that's really the most important thing to see here. And we know that it helps the patients. So how do we measure head and neck cancer related lymphedema? There's a few different scales that have been published historically, and I do hear people talking about this at meetings from time to time. We have what's called the Foldy classification and the Patterson scale, and people have tried to give numbers to it. But I'm somewhat skeptical about some of these external measurements. These external measurements can be complicated by the fact that our patients are routinely losing a lot of weight. They're accumulating water volume. Their muscles are atrophying. Their tumor itself in the neck can be changing in size dramatically. They might be having surgery. There might be differences above and below the neck scar. And so these measurements, I think they're at best okay, but they're probably not telling us the whole story. And so our research team, when we sat back and looked at this problem more than 5 years ago, we said, well, what is really a good way to measure lymphedema? What is something that we already regularly do as part of head and neck cancer treatment, right? We don't want some kind of complicated multi-million-dollar gizmo. We need something that kind of is at our fingertips. Something that's low or no cost, that all of the different providers, the physicians and the allied health providers can see it and can talk about it in a similar language, and that we can compare patients to their own baseline so we can monitor their progress. And the answer was kind of under our noses, no pun intended, but it was really what we see with our examinations, our scopes, and what we see when we're scanning patients. And we know that cancer patients are getting a lot of scans and a lot of scopes. So if you're looking for lymphedema, you're not sure you're seeing it, and you're looking at scans the way I do, you're seeing it all the time. Our radiologists, when they look at scans after treatment, we can ask them, well, let me show you a scan, Dr. X, could you tell me if this patient had radiation the last 5 years? they unanimously can. It's very obvious to the radiologist. So what are they seeing? Well, they call it post-treatment changes. If you look at the typical CT scan report of a neck CT, let's say 6 months after radiation for a tongue-based cancer, you're going to see in there post-treatment changes. And we tend to kind of fly past that. We don't stop to think, what do they mean by post-treatment changes? But what they're describing as lymphedema, of course, radiologists don't think about lymphedema. That's a clinical term, not something that is in the radiology textbooks. But let's narrow in on that. So here's a sagittal view of a patient pre and post radiation for a tongue-based cancer. And what you see here highlighted in blue on the left is a normal epiglottis. And on the right, you see the epiglottis after treatment. And so you can see that the lining of the epiglottis, the mucosa, is edematous. And it's not the mucosa, it's actually the submucosa, right? It's just what under the lining that's thickened. And that is lymphedema. So it's lymphedema, but we're calling it something else in the radiology world. We're calling it post-treatment change. And the speech therapist in the room will tell us that, of course, when we see this kind of edema, we have to also think about the vallecula. The vallecula is the valley between the tongue base and the epiglottis, shown on the left there with a little blue shape. And when your vallecula is gone on the right side, it changes your swallow. It doesn't give space for your epiglottis to elevate, and it cause problems down the road. So here we're connecting the same phenomenon internally, and we're giving it, we're saying, hey, what you're calling post-treatment changes, I'm calling lymphedema. It is the same phenomenon, and it is back to swallow again. And so we went and looked at something that others have studied before us, and it's kind of a no-brainer study, but we looked at patients who were undergoing radiation therapy and just looked at what happens to their epiglottis and what happens to their posterior pharyngeal wall and essentially all the lining in their throat. And these are patients who are universally, cured. And what's interesting is that the lining is almost double on the epiglottis, on the posterior pharyngeal wall over time. And for many patients, that persists for a great period of time. The only patient here that was that light blue line in the bottom that never had that big jump in the thickness of the lining of their epithelium, and not developing lymphedema of the common structures in the throat, is the one patient who was treated with a surgery alone and didn't get any radiation. And but all the rest of them had significant jumps in the thickness of their mucosa and of their lining, and that speaks to that's lymphedema internally, which we talk about more and more. So we come back to the audience again, and we ask you, what do you make of lymphedema internally? How important is it to measure internal lymphedema? Do you measure it? You don't know how, or you don't have the time or the means to measure it, or do you talk about it sometime, or is it ever present in your mind, and you measure it all the time and you use it to track the recovery of patients? And not surprising, we're getting about 75% of you in the audience today saying it's important, but I don't have the time or the means to measure it. And that's not surprising. There's a small group of you who say, I don't measure it. And there's a small group of you who say it's important and I measure it all the time. But like all of you, I live also in category B, where I know it's important, but I don't really have a tool to measure it, but I see it all the time. And that's not an uncommon finding. So I'll show you internal lymphedema as we see it day in, day out, and how we've changed a bit how we talk about internal lymphedema. So this is a patient who actually never had throat cancer. She had cancer of her saliva gland, or her parotid, never had any surgery to the throat, but she had extensive surgery and then radiation to the left side of her neck and parotid bed. And she comes into the office 6 months later, and she's complaining of voice problems and swallow problems and neck tightness. So that seems a bit distant from the parotid gland where the epicenter of her disease was, but this is not an uncommon thing. For those of you comfortable with, a bird's eye view of the larynx, if you look at this larynx, the speech therapist, I'm sure in the room and others will be able to quickly identify which parotid was treated. So the parotid is a saliva gland in front of your ear, as all of you know, but I'm showing you the larynx, and you can tell that it was the left side that was treated. So why are we seeing a arytenoid swelling on the left and not on the right when the patient had a parotid cancer and parotid neck operation and left neck and parotid radiation? Well, it's lymphedema. And this lymphedema on the left arytenoid's really the focal point of her problem. The right arytenoid looks perfect. It looks normal, nice thin mucosa. And when we look at the arytenoid, we see it here nice and normal on the right, totally fat, thick, edematous on the left. And here again, we have language problems. What the radiologist will call post-treatment changes, we call, laryngeal edema or, post-treatment edema in the larynx, but we really should be calling it lymphedema. On our scope exams in the ENT clinic, we should be saying left-sided supraglottic lymphedema on this scope evaluation. That's really what we're seeing there. And this patient nicely got a CAT scan on the same day, so we can correlate it to the CT scan. So here's the nice right arytenoid, and here's the left arytenoid that's much bigger. And of course, our speech therapist will again remind us that this piriform sinus is really where all the swallowing action takes place. The right piriform is open, it's ready for food and liquids. You won't aspirate down the right side, but the left side is effaced. They'll see it on a modified barium swallow, they'll see it on a FEES. And the speech therapist, of course, will tell the patient to tuck their chin and turn their head to open up the right piriform to try to get food down there. So here again, we've got something that the speech therapists know. They know it like they know the sky is blue, but we don't really think so much about it, except that in this patient, she'll benefit from that visit with the speech therapist and that advising from the speech therapist. And we see it again on the CT scan. So we take a step back into the basic sciences for a moment here to connect all these dots that we've made today. These ideas about internal lymphedema and external lymphedema, this idea of swallowing and lymphedema, what's happening externally on the neck and internally. And I told you earlier that we did this really neat study some years ago with my research partner, Eva Sevic, that I'm sure some of you know, where we took patients who were newly diagnosed with head and neck cancer and we imaged their lymphatics. And then we imaged them again every 6 weeks as they went through whatever treatment they had. Was it radiation and surgery, or was it surgery alone, or was it radiation alone and plus minus chemo? And we just tracked, we're just watching the clouds, so to speak. We're watching these lymphatic maps and we're seeing what's happening. And so the phenomenon we were able to start to see was something called dermal backflow. And not surprising that we named it dermal backflow. It's happening in the dermis. It's happening just under the lining on the skin externally. And of course, in parentheses, we know it's also happening under the lining, under the mucosa on the inside. But these cameras really only can see about a centimeter or two deep. And what you see are these fluffy clouds, if you will. Look at number 4 and number 5, where the lymphatics are trapped and they're recirculating. They're looking for a place to go, but they're not going straight down the neck. They're kind of stuck up along the jawline. And they're trying to make new roads over time to get lymphatic flow moving. And this correlates to the development of lymphedema. So now for the first time, we can actually see what we can feel, but now we can actually see it. And this is a video that I think is probably not going to work very well. Suffice it to say, we learned some things, because we had so many different patients in this trial. We had patients who had, let's say, a tonsil cancer, so they had surgery and radiation to one side. We had patients who had tongue-based cancer and they had surgery to one side and radiation to both sides, and so on and so forth. And what we learned, of course, was no shocker. It's an indictment, really, of the way we treat patients. The more you have done to that side, the more you'll have lymphedema. So surgery does cause a lymphedema, but it causes a very transient one. That even when we do thyroid surgery, we see some edema above the scar, and it tends to go away after about a month or two, and the body heals very quickly. But add radiation, external beam radiation, to a neck scar, and it's a totally different story. And so it's not surprising, without getting too deep into the weeds here on this slide, it's not surprising that patients who are getting both surgery and radiation to the same side of the neck are getting much more lymphedema than ones that get just radiation alone. The ones who have just surgery alone are getting very transient lymphedema. And in a lot of patients, you could see the difference left and right, just like I showed you with that parotid cancer patient, where they are acting as their own controls. And if you look at patient number 13 here, you can see that we're measuring a tremendous amount of dermal backflow on the side that was treated, and none on the other side where the lymphatic flow is good. Why is that important? Well, as the lymphatics reorganize, and as you lymphedema therapists, so many of you on the phone call are lymphedema therapists, it may change to some degree, perhaps, I don't know, how you try to move that lymphatic fluid. Maybe we try to move it to the good side as opposed to just trying to move it down. And I think that's very important. So also often we find that the patients have kind of one side of the neck that's dominant for lymphatic flow over the other after this kind of treatment. And we've published these papers over time, and I show them here just so that you can reference them after the talk about the basic science. So what have we learned about lymphedema therapy and what works? Sometimes I'm at the supermarket and I see a breast cancer patient, and she's wearing a lymphedema garment on the arm. The lymphedema garments that people wear on the arm, I'm sure work quite well. The problem in the head and neck is what you see here with this patient on the right. If you really were to wear a garment, you'd have to wear something like this, which probably would work, but wouldn't be very conducive to driving kids to carpool or going to a business meeting, or being an accountant or a nurse or any type of job for that matter. And so what we can do with the arm with compression bandaging is probably just not as effective in the head and neck. And this diagram on the left is from a textbook on lymphedema therapy, which shows what I had talked about before, this kind of broad idea that everything just has to flow down. But I hope that what I showed you in those papers helps to explain that it's a bit more complicated than just down. Sometimes the lymphatic flow goes way around to the other side before it goes down, and the lymphatic flow is different in every patient. And if you look at it carefully, you'll study it and see it. We have another problem with head and neck lymphedema, which is that we see the patients, let's say, every 6 weeks or 2 months, but their problems are every day. And as you know, medicine is going from the operating room to the clinic and from the clinic to the home, and so much more is being done at home now. Add to that the COVID pandemic, and even more consciousness has arisen around this idea of avoiding the doctor's office or the speech therapist or lymphedema therapist's office. But the good thing about seeing a lymphedema therapist is that it's an incredible experience. I've been in the room with our lymphedema therapists, and I've borne witness to the work they do, and patients feel better instantly. It's really quite impressive. I always share that to my MD peers. I said, go watch this for 30 minutes and see how the patient feels. They feel better after manual lymphatic drainage. It's a real thing. The problem is who's going to do the manual lymphatic drainage tomorrow and Wednesday and Thursday and Friday and Tuesday and Saturday, and in between visits. So if you're lucky to be married to somebody who knows how to do MLD well, then you're golden. But for the rest of us, we need another way to get this done. And we know that patient compliance is a big issue as well. This is part of the reason why the company Tactile, which has sponsored this evening's talk, and which I'm such an enthusiastic supporter of, this is why they designed it the way they did. And so that you can have a pump that you have at home, that you can watch Netflix like this gentleman here, or you can have your cup of coffee and get some version of lymphedema therapy. This is not a replacement for MLD. This is your take-home homework in between visits with your lymphedema therapist. Lymphedema therapy is a lot more than MLD. It's a lot of education and other things. But in between visits, if you're doing this, your life is better. And we hear this from our patients, and I'll share that data with you. And so when do we prescribe it and how do we prescribe it? Well, number one, our patients are educated on lymphedema very early in the treatment. Even before they're done with radiation, they're aware of it. But we reflexively refer to lymphedema therapy, speech therapy, and for a garment as they approach the end of their radiation therapy, if not earlier. Most of our patients will get this garment. How quickly they'll wear it depends on how quickly the mucositis resolves on their skin. Most patients by 4 weeks after radiation is done are wearing it. And this is an important point. A lot of places wait for 6 or 9 months. And when there's persistent problems, Then they start to look at lymphedema therapy, and I would say that's a mistake. First of all, if you wait that long, you've missed the boat and fibrosis is settling in, and it's hard to recover swallowing 9 months after you haven't really swallowed well nor gotten any therapy for it. And number two, we can safely assume that all patients will have some benefit from this. Now, the poor analog to lymphedema therapy is actually exercise. And we know that patients who are very active after head and neck cancer treatment are kind of doing some of their own lymphedema because the body acts like a pump. The muscles are working and pumping fluid and so on and so forth. But for most patients, especially in this era of COVID, they're at home, they're not in the gym. It's hard to get cancer patients to the gym anyways. And not all patients are going to be compliant with that. But with this, they're very compliant. This is a passive thing, so they can put it on and they get it done. And so the compliance is much higher than home MLD or, hey, you should go and try to move your shoulders and neck more. So the critical questions come, and we're just about 10 minutes out here. So I'm going to try to wrap this up in about 5 or 7 minutes, and we'll do about 5 or 7 minutes of questions, maybe a little bit more. But does the Flexitouch, this tactile device, improve the movement of lymphatic fluid? And more importantly, does it actually improve the quality of life? And so we've studied this as well. And you can see here that the backflow, this is a patient, and then 2 weeks later, 2 weeks of daily tactile Flexitouch treatment, 30 minutes in the morning every day. And you can see the same patient 2 weeks later, and now you see this bright yellow light in B. So lymphatics are actually reaching some of those important deep regular nodes, and lymphatics are flowing. And this is apples to apples, one patient after another. Here's another patient, same thing. This is before 2 weeks of treatment, the same patient after 2 weeks of treatment. You see the lymphatics beyond the dermal backflow and getting into some significant lymphatic flow into the deep lower lymph nodes where they can actually access the chest and get treatment. We also know that internal and external lymphedema are connected, meaning you can say, well, Ron, I'm treating external lymphedema with a Flexitouch or manual lymphatic drainage, but what does it do internally? And that's the other part of dermal backflow. Dermal backflow actually is the phenomenon where internal lymphatics and external lymphatics are stuck together and don't have a way down. If we treat the external lymphatics, the internal lymphatics then have flow. It's kind of like a highway traffic jam. If you're 3 exits back and then 6 exits back from the traffic accident, you've got to solve the downstream problem before the upstream one. And so by treating the external lymphatics, the internal lymphatics drain better. And we see that on lymphedema imaging studies. And we also see it clinically with patients, which ties us back to this idea of what's under the chin. This under the chin thing is aesthetic, but like I told you earlier, it's also the tip of the iceberg, and it's an important sign for us, weather vane, if you will, that they are having lymphedema internally as well. Because remember, the treatment was not focused to the skin under the chin, it was focused inside. We know that patients who get Flexitouch treatment at home are 4 times greater improvement in their ability to swallow solids. And that's really important. These are some of the really important studies with great p-values shown there, showing that things like swallowing and external swelling and their pain even from the swelling is markedly improved by a daily treatment of Flexitouch. And this is simple. They wear it at home. They can be drinking their morning cup of coffee. We see patients, for instance, who have terrible edema of their larynx after laryngeal cancer treatment. They don't have active cancer, but they're edematous to the point where they need a trach. And we give them lymphedema therapy, and their airways improve to the point where they can be decannulated, which is a huge quality of life difference. Take a trach out of someone's neck and say, you don't need this anymore, and you'll see the smile on their face. It's a huge, impressive difference in quality of life, and it's lymphedema treatment that can make the difference. Here's another study showing more or less the same improvements in swallowing, in mucus-related symptoms, in pain, in restriction of movement, p-values, all excellent. And I'm just going to move right past this for time and come back to where we had started with this idea of this under the chin. Here's the challenge for you. If you've not been in front of a Flexitouch and a cancer patient, try it. Call the local tactile person. They're wonderful. They will come to the office, call in a patient, somebody who's, let's say, finished radiation 4 to 6 weeks ago. have that patient come in and have them come in at 9 o'clock in the morning and put the Flexitouch on them. It costs you nothing, have the rep bring it in, and then 30 minutes later, take it off and tell the patient, how do you feel? And tell them to drink a little some water and say, how does the swallowing feel? It's really impressive, actually, to see what 30 minutes of lymphedema treatment can do to a patient. These are what the external looks like, but the internal does as well. And finally, my own story, which I've shared with you this evening, really comes back to patients like this gentleman on the right. There's a video here, but we'll skip it for the sake of time. But this was a gentleman who had tongue-based cancer, who got radiation and was for all means and purposes cured, but was still peg tube dependent for about 6 months, despite excellent speech therapy. He's kind of our old Texas guy here, but he was doing it all right and not getting better. Speech therapy was working with him and we couldn't figure it out. I even took him back to the operating room to take a biopsy to make sure I wasn't missing cancer, because he had some pain with it. And this was many years ago when I first started getting exposed to the Flexitouch. So I finally said, okay, let's try this gizmo that I had just heard about. And we put it on him. And when he came to the office 3 weeks later, I could show you the video another time if you want to, but the feeding tube was out and he said, it's like he put it on and immediately was swallowing better, feeling better, and was finally recovered. And that's really the story here. The story today is of the low-lying fruit, the things we can do to help our head and neck cancer patients get better, the things that are FDA approved, that are often approved by the insurances or by the VA or by the hospital we're aligned with, the lymphedema therapists that we really need to get on our speed dial. And we need to tell our staff in the office, don't ask me if a patient needs to see a speech therapist, a lymphedema therapist, just reflexively accept that we think that should be a standing order for all of these head and neck cancer patients. It should be agreed upon. The whole team should get together and say, yes, we think all head and neck cancer patients who are getting, advanced treatment, let's say radiation plus minus surgery, should at a minimum see a speech therapist and a lymphedema therapist and be referred to get a Flexitouch. The Flexitouch is kind of neat also in so much as that the company sends out people to the house. They do it, of course, in a COVID-friendly way nowadays. They'll tell you more about that. But so it's easy for the patient. They don't have to come to an appointment. They don't have to pay a copay. They come to the house. They measure the patient, and then they teach them how to actually put on the garment and use it, and they check back with the patient periodically, and that makes us look good, meaning we finally have a treatment for patients at home, and it helps them when they come back to the office. They feel better. The vast majority of patients who put a garment on will wear it. It's exceedingly rare in my practice, less than probably 7 or 5% of patients who try this and say it didn't make a difference for me and don't wear it regularly. And so with that, I want to thank you for joining me this evening. We are just 2 minutes shy of the hour. I hope that we have covered the cardinal points here about lymphedema really being an internal phenomenon tied to swallow, the cardinal role of lymphedema therapists, yourselves, swallow therapists, occupational therapists, and others in the recovery of head and neck cancer patients. And that we've kind of properly introduced and positioned not just lymphedema therapy, but this at-home lymphedema tactile Flexitouch for our head and neck cancer patients to improve their quality of life. So I'll turn it over to Brittany now, and we'll take some questions from you. Thank you so much.
Yeah, thank you, Dr. Karni. Wonderful talk. There was a lot of great information there in that presentation. We only have one question so far. So if you do have questions and you're listening in, feel free to type them in the Q&A, but I'll throw you this one right now. Have you heard of, or do you think about using a low-level laser to treat fibrosis of the neck?
I'm increasingly curious about this technology. I have some close personal friends who are head and neck cancer survivors who've used it. I have one who swears by it. He's actually a very well-known cancer patient who wrote a book about being a laryngectomy survivor. His name is Itzhak Brook, and you could find his book online and at Amazon. And I've had dinner with him a few times, and he swears by it, and it intrigues me. There are a bunch of other little gadgets and knickknacks that help. that we haven't really uncovered completely. They probably work in different ways, and they may not just be attacking the mechanism of lymphedema. The low-level laser may actually be treating the mucositis, the actual lining, not the underlining swelling that is lymphedema. I think that's a big one. The other big one that actually comes up quite a lot in these talks is Botox. And there's a lot of patients who develop musculoskeletal side effects of radiation. And we ENT doctors are terrible at orthopedics, and we don't like to think about the spine. We think of it kind of as what's beyond our frontier. But we know there's a lot of spine problems in patients many years after radiation, and they get shocks of electrical kind of like a lightning spasm of their SCM and their trapezius muscle, and they find themselves stooped kind of forward. And that also affects the airway and swallow, but of course, their quality of life and chronic pain. And so there's an increasing number of specialists in the rehabilitation world who are trying to use Botox and some other interesting devices that help hold the chin up. I talk about this a lot with my patients. I see them over years becoming more and more flexed in the neck. And we talk about either a device different than the lymphedema device, a postural device, if you will, almost like a seat collar, and physical therapy, of course, and other things to ameliorate these problems. So there are definitely other things besides what we've talked about here this evening that can also help other aspects and other side effects.
Great. I have a few more questions that are just coming in. So here's one. Wondering if completing swallow exercises while using pneumatic compression would reduce the internal edema, similar to exercise while bandaged for lymphedema of extremities.
Yeah, so I kind of made a side comment to this earlier, and the kind of the I say this with a wink and a smile, but if I can massage your epiglottis and your supraglottic structures every morning, I think that your lymphedema would be better with some MLD there, but you can't get in there. And this is probably, again, why breast cancer and head and neck cancer lymphedema are different. But we do know there's a connection. The lymphatics are anatomically connected internally and externally. They're, of course, anatomically disrupted with surgery and radiation, but these lymphatics are trying to work their way out. Gravity makes a big difference. We know that when external lymphedema gets better, internal lymphedema gets better as well. And we know when we treat external lymphedema, or when we treat lymphedema externally, whether it's MLD or with like a tactile Flexitouch, that swallowing gets better. So we know these things are connected. And to me, the missing piece was the dermal backflow, meaning the dermal backflow is kind of a way to see it. If you ever, if you pull up our papers, or if you ever want to pop into my office, if you're in Houston, we can show you on a screen how that connects the internal and external lymphatics and helps. So internal lymphedema is really the focal point, but we can MLD it directly, so we treat it externally.
One more question. What about dolphin scar microcurrent stim? That's not my language, but maybe you understand what that is.
Say that one again. I don't know it.
Dolphin scar microcurrent e-stim.
Oh, eStim, yeah. So again, it's another one of these great technologies that are being developed. I am going to withdraw myself as an expert on that. I do have some patients who have, and this is what's interesting, right? Patients will find these things, and some of these technologies are actually very effective, and they're effective in some patients, maybe more than some patients. They need to be studied. And so eStim is one of them. I've heard of it. I don't want to pretend to be the expert on it. I think there needs to be a lot more data like we've shown here to get it out there, and we've got to educate folks about how these things work. But I do hear about it more and more, and I hear about it from the speech therapy community, which is interesting. And so, thumbs up to it, but I don't want to pretend to be the expert on it.
Can Flexitouch be used with a PEG tube in place? And when do you refer for Flexitouch?
Yeah, I'm happy that question came up. So definitely the PEG tube and the Flexitouch are, in fact, one could say that because the patient has a PEG tube, they're not swallowing, and in turn, they probably need a Flexitouch badly, right? Because they need to recover that swallow. And and we talk a lot about pathways. I probably didn't talk about pathways enough this evening, but pathways is really this idea that you can get in a room with everybody from the medical assistant to the surgeon, med-onc, rad-onc, the allied healthcare providers, the you folks, the PT, OT, STs, lymphedema therapists, and you can say, we as a team decide that we think all patients should see a speech therapist, within 4 weeks of diagnosis of oropharynx cancer. And everyone shakes their head yes and agrees. And now no longer do we have to wait for the physician to prompt that. Anybody, and in fact, everybody in the practice is responsible and accountable for that. So we tell patients in our practice, you haven't seen a speech therapist, you've been diagnosed for 4 weeks. What happened? How did that not happen? And the same is true for the lymphedema therapy. So we reflexively, for anybody who's getting radiotherapy, refer to lymphedema therapy, and underline the word and, refer for a tactile Flexitouch. And the sweet timing for this is, at any time. Earlier is better. So my tactile folks are integrated with the practice. So I'll tell them, okay, Jimmy was diagnosed with oropharynx cancer. He's starting radiation next week, and they'll make some initial contact with the patient. Say, hey, here I am. I'm your lymphedema guy. We're going to work with you as we get a little bit further on. But in fairness, most patients don't want to actually don the garment for about 3-4 weeks after radiation started. But that's when they're most eager to don it as well, because they're looking for remedies to get better. And again, I don't like the idea of let's wait and see if you get lymphedema. When I hear that, I always challenge the person across from me on the panel and say, well, how do you know when the patient gets lymphedema? Well, when they don't get better at 9 months, you've kind of missed the boat. And so we do it preemptively. And this is not novel. Look at the breast cancer world. Women are much more knowledgeable about medicine than men. They're much more plugged in. They're much more likely to call a friend and say, how did you deal with this? They're much more likely to go see a doctor. What breast cancer treatment center in the United States puts a woman through an axillary node dissection and radiation and doesn't reflexively refer her to lymphedema therapy? Everybody knows that she needs it. So why is the head and neck different? We have muscles, nerves, arteries, veins. We've got function. We've got swallowing instead of the grip of the hand. Why would we not reflexively do the same in the head and neck? And I've never found a good answer to that question. And I know the answer is we should be.
Here are a couple of questions, and it's very applicable to this audience because you mentioned that a lot of physicians don't know that much about lymphedema. And so here is a PT and CLT saying that, his main problem is that his MDs don't have enough knowledge on lymphedema, and he can't persuade them about the importance of that in the head and neck. What should I do to persuade them? And another question similar to that is, what do you believe the best way for SLPs to refer patients with suspected lymphedema to their MDs? So it's kind of that question of how do we convince our MDs that this is a problem?
This is a big problem, and it's there's no easy fix. And I don't want to pretend that the MDs are easy on this topic. They tend to be typical for MDs, right? They've got 10,000 things to do. The medical records, the electronic medical record is calling their name. They've got 5 phone calls to return, and they're not classically trained in this, so they just see it as outside their purview. And I can only tell you this doctor's experience, this guy standing in front of you tonight electronically, is that I was a bit shamed by my own patient experiences, meaning that patients who went and got lymphedema therapy without me referring them came back to me and said to me, shame on you. They didn't say it like that, but they said, I got lymphedema therapy despite you not referring me, and it made me better. Or, my cousin's a speech therapist and she got me into speech therapy and it got me better. And you probably should do this more on your other patients. And so that was kind of a wake-up call for me in my early years in practice. 2 other data points I would say. Number one, it's physicians do like things that happen automatically. We like shortcuts. And so, like I said earlier, it's not a bad idea if you are the physical therapist or lymphedema therapist and you have the MDs to say, hey, look, can we meet for 10 minutes at the end of tumor board? Or faculty meeting or cancer committee or whatever it is. And during those 10 minutes, you say, look, do you agree that all of your or all your throat cancer patients, or oral cancer, nasopharynx, oropharynx, hypopharynx, and larynx, patients need speech therapy. Yes, I agree. He or she will tell you. And then you say, okay, well then can we just make that a blanket order that everyone in your office knows so I don't have to bug you for it? And he or she will say yes. And then it's a matter of going into their office and making friends with the, every office has a nurse Susie or somebody who actually makes everything happen. You've got to find that office manager and say, look, Dr. Smith just told me that this is how we're going to do things. That's a pathway. That's what the best practices do. And the same can be done for lymphedema therapy. For lymphedema therapy, I would go a step further and obviously have the tactile people come in and do what I challenged you before. Find that 6-week patient, show up with the lymphedema therapist and the tactile Flexitouch and the tactile rep, and do it in his or her office. Say, look, we got Mr. Jones. He's 6 weeks post radiation. We're going to do this, and do you mind just popping your head in for a minute and seeing what you think? It sounds like a pharmaceutical call or something like that, but actually I think the doctor's eyes will open. And then the final thing you can do, which we've done, is we've done kind of like brief interventions, if you will. So I myself have actually gotten in front of many audiences. I want to say probably 30 or so traveled myself. Happy to go out and meet. I've met with the major academic centers. I've met with small community hospitals where they're doing good cancer care. We kind of listen and say, okay, what is your state of the art? And then how can we help you mobilize the people you have here in this neck of the woods, so to speak, to get this to your patients? And sometimes kind of a 30-minute roundtable with somebody like me can really click and make the difference. I know that in a lot of cancer centers, head and neck it's not like breast or prostate where it's top of mind all day long, but a lot of doctors will lean in for that and say, oh, I didn't realize, I heard it from another MD. I know it's real now. And so those are all ways to do it. If you want someone like me to come out and do a Zoom or come in person, we can do it. Just shoot me an email or give me a call. That's another way to get that done. So maybe these are all little strategies to help.
Great. A couple more. One is for our head and neck patients, we emphasize a lot of exercise to minimize the effects of radiation therapy. So they're in Canada, the pump would not be covered and very expensive. We see great results though with a combination of a night garment, self-MLD, head and neck exercises within self-management. Does your center try this combination prior to using the pump, which perhaps might be expensive?
In addition to, I would say, rather than instead of. So the good and the bad news. The good news is exercise is huge, and exercise is also lymphedema therapy, just like swallow therapy is lymphedema therapy. Swallow exercises is actually manual lymphatic drainage internally. The same can be said about exercise. The problem with exercise is compliance, and we all know that to be true. And so this is where I think the Flexitouch is better because it's much more likely, patients are more likely to be compliant. But I hear you loud and clear in Canada, and I'm not pretending that we have easy access to the device there. And I credit you with exercise. I talk about exercise all the time with my patients. I talk about taking 2-pound weights, one in each hand, and doing basically everything that you could do with the 2-pound weight from the nipples up, meaning the shoulders, the trapezius, the latissimus, a little bit of the biceps and triceps, neck range of motion, and things like that. And I do think that makes a big difference. We do also have this generation of kind of the CrossFit guy who gets head and neck cancer and is eager to go back to the gym, has a lot of protein wasting and really wants to get back to, his or her CrossFit body. Those patients are dying to go back to the gym, and they do have less lymphedema because of it. They tend to recover better because they're active.
All right, I think there's a couple more questions about Medicare, so I'll cover this one. So there is wanting to address Medicare coverage for the Flexitouch, and unfortunately, Medicare does not cover the Flexitouch device, but here at Tactile, we are working on that. We have been continuously working on trying to change that, and we are going to be engaging in a larger randomized control trial that will give even more results hopefully similar to what Dr. Karni already presented. And I will say that most commercial payers do approve the Flexitouch for head and neck patients. So we are working on that, and hopefully we'll see positive changes in the future. This
Brittany, let me chime in
presentation,
on that for a moment, if you
yes,
don't
please
mind.
do.
I think it's a really important question. So I'm gonna take I'm going to give you my perspective on it. Number one, I try not to ethically change how I treat patients based on insurance. And so I universally refer everyone to Tactile and for the Flexitouch. And Tactile's been phenomenal at trying to find ways to get patients who don't have the appropriate funding the device. Some devices are donated back. There's all kinds of ways that they can get it done. And so I don't stop and look at the insurance to try to figure out what to refer to a patient. I've never done that, never will. The other thing is that all devices like this go through this kind of stepwise approach. The commercial payers will pay for it first. Often they'll ask for extra notation. They'll say, has the patient, had some lymphedema diagnosed and so forth. So you've got some forms to sign, and the Tactile rep will probably chase the doctor for a form here and a form there, and they do that very well. But it's typical for new devices in this arena, in this space, and it's happened in the breast world as well for lymphedema, where the commercial insurance providers to cover it first, and then ultimately CMS, which is Medicare, Medicaid, will follow. And to Brittany's comment before, we've actually gone to them, heard what questions they want answered, and have a big multi-center clinical trial in the United States right now that is ongoing to answer those questions so that we can finally get that Medicare approval. So coming soon to all payers, but the VA, for instance, covers it universally, and like she said, commercial providers are quite good at this now.
Great. Well, we are kind of at our time stop, and for those questions that we haven't gotten to, we can follow up individually after this webinar, and also it will be recorded on the Tactile Medical website. And we do have some additional webinars. If you would like to learn more about lymphedema in other areas of the body, you can go to tactilemedical.com and register there. So thank you so much, Dr. Karni. This was a great webinar. We have a lot of comments in the chat. Everyone seems to have enjoyed it. So we are very grateful to have had you speak tonight.
Thank you, everybody. And all around the world, I see some people. And so thanks for participating, a real honor and pleasure.